afternoon, everybody. As folks are finding their seats, I'm going to take the host moderator privilege and get you to do a little activity. I'm Ignatius Bao. I'm an independent health equity consultant, and it's really my privilege to moderate this great panel about health equity across the care continuum of how particularly health departments and community-based organizations can partner with health plans, hospitals, and health systems to advance health equity. So the interactive exercise is how many people are from outside of California? Either stand up or raise your hand. All right, good. How many people are from community-based organizations? Okay, great, welcome. How many people are from health plans? How many people are from health departments? Yay, thank you. And then finally, how many people are from hospitals, health systems, and health providers? All right, so nice mix of folks. And looking forward to hearing from our panel of the different ways in which we're trying to partner across all those different parts of our healthcare ecosystem. So I'm going to start with the first panelist. Tony Gonzalez is the Executive Director of the Fresno Community Health Improvement Partnership. It's a partnership of over 150 organizations in Fresno County, and Tony will start by telling us a little bit about how the partnership came about and what it's currently doing on health equity.
Thank you. Good afternoon. So now I'll join in the fun. How many of you know where Fresno is? Hey, all right. Yeah, we're lucky we share a little national park in our backyard, right, Yosemite. So thank you for stopping by Fresno. Let me know when you're in. We'll do a Fresno tour. Fresno Community Health Improvement Partnership. This partnership started about 7 years ago. We are a nonprofit organization with the intent to improve health outcomes in Fresno County. Some of you may have read some literature that Fresno County, the Central Valley, is likely the next Appalachia in the West Coast, right? So poverty rates are skyrocketed, especially after the pandemic in our region. And some of the work that we have embarked in is, of course, building the community health worker infrastructure. Some of my experience, just to share a little bit about me, is I am born in Mexico. I was brought here when I was 7, and I've lived in the Central Valley ever since. I've worked with a national health plan and a local health plan over the last 19 years, and now am doing this work on the nonprofit side. Fresno Community Health Improvement Partnership works closely with youth. We just developed our Youth Leadership Council, which is intended to be equipped as the next health equity leaders in our community. We have 23 high school and college students who are being trained on ACEs, and they're doing service acts in their community, focusing on ACEs aware stress busters, so that we are able to provide some resilience in the community. The Youth Leadership Council is also working very closely with the FCHIP, the Trauma and Resilience Network. That is one of our work groups that helps link individuals as well as students to mental health services, as well as available trainings around mental health and community health workers and trabajadores comunitarios y promotores, right? So a lot of the work that is happening at the FCHIP level with TRN, Trauma and Resilience Network, is really intended to build community resilience and be able to equip our youth as well as our community health workers and our medical and healthcare professionals on being able to deliver trauma-informed care. Some of you heard earlier this morning, we can't have quality without equity. I would argue that we can't have quality without equity, without abolishing racism, and without trauma-informed care, right? So that's a little bit of some of the work that we're doing on the FCHIP front. We are also one of the California Accountable Communities for Health Initiative sites, one of 37 and one of the original 13 from a few years back, receiving funds to do some of this great equity work. The other component that I want to mention to this group is the work that we're doing with community health workers through the Fresno Hope Hub, using the Pathways Community Hub Institute model, an evidence-based approach to community health worker and achieving quality as well as outcomes. We are working with 7 care coordinating agencies and over 35 community health workers who are from the community, speak the language, live and work in the communities. Remember also from this morning, the magic wand? We have the magic wand. Now we need to build capacity. Now we need to invest in the work that is happening through the Fresno Hope Hub, through the Pathways Community Hub Institute model. And we're also collecting data on 21 pathways. We're doing over 150 hours of training for community health workers to ensure that they have the capacity, to ensure that we, as the Fresno Hope Hub through FCHIP, are also learning from their subject matter expertise, and that we are also listening to the needs that they have, whether it's based on their career goals as a community health worker, trabajador comunitario promotor, say that 3 times, or just as an individual who is trying to deal with the trauma that you also get for providing this very heavy, heavy work that community health workers get to do, right? So I think I'm probably out of time. So I'll just share a little bit about the funding. Some of our funding sources, we like to call that braided funding. We have funding partners, which include the county departments. We have funding partners, which include Medi-Cal health plans. We have a new partner, State College Community Center, local school districts, as well as grants. And we are now a CalAIM community supports provider, and we'll be leveraging the community health worker benefit as well.
Great.
So with that, thank you for your time.
So next up, we have Kitty Bailey, who's the Chief Executive Officer of the San Diego Wellness Collaborative. And the San Diego Wellness Collaborative has continued to evolve from the original partnerships that they had between community and clinical providers to now really taking an active role in the CalAIM Medicaid implementation here in California. Kitty.
Hi, everyone. It's good to be here. I'm going to talk today about our role at San Diego Wellness Collaborative operating what we call neighborhood networks, which is a hub. So just to get into the action, how many people in the room are familiar with the concept of community care hubs or intermediaries with social service agencies? Okay, good. So growing awareness that this is a new kind of organization that is evolving and growing, especially here in California, for the Medi-Cal population under the CalAIM transformation. So our role is to really try to make this easy, to create a network for social services or more broadly non-clinical community-based organizations to participate in the new CalAIM contracts. And as a hub, we do a lot of things that you might think of an MSO or an IPA doing. So we do contract administration, contract compliance, we do claims administration, we have a case management system that we are building out to have data exchange with our HIE and CIE in San Diego. But the case management system is a shared tool that all of our network partners use. It includes decision-making tools and care planning building tools within it. And we also have a learning management system so that we have standardized trainings that we can offer to the workforce. And we do CBO capacity building and technical assistance. So that's a lot. It doesn't really bring the heart of it out, which is that we work hand in hand in partnership to transform the way we do business. So a lot of us are deeply in the weeds on the CalAIM implementation and all the new workforces. So we can rattle them off. ECM lead care managers, housing navigators, doulas, CHWs. We're soon going to have certified wellness coaches under the multi-payer fee schedule at schools. And I can tell you from the perspective of somebody working closely with our CBOs in San Diego County, this is creating chaos. The new populations of focus is creating chaos. Nobody knows what is going on. We also have children and youth behavioral health initiatives. So yeah, I think we all applaud the state. This is, an amazing time to work in healthcare policy and the translation to the community, because I've never seen anything like it try to be achieved. And I don't think we pause enough and ask ourselves, whoa, how is this really going to get done, feet on the street? And that is really the role we play at Neighborhood Networks, is helping all of our partners engage. It really starts with just, why should they care? Either there's like this hypothesis that like CBOs can't wait to take Medi-Cal contracts, which I don't know where, that's not necessarily a starting point. So really it's about making sense of this Medi-Cal world to our community-based partners. I had the good fortune of having the Accountable Community for Health grant since 2016, and having convenings and tables and meetings where I would watch the managed care organizations and the CBOs, who are serving their members every single day, have no idea what each other were talking about. And I forecast out and said, how are these people going to go under contract together? And both experience this as a positive, affirming transformation of the way we do business for the Medi-Cal members. So back in 2019, we started taking contracts with health homes, and since then we've served over 1,000 clients through health homes, enhanced care management, housing trio, and now CHWs. It has been an incredible journey. We have had so many good partners along the way. All the managed care organizations have been wonderful partners. Our local foundations, California Healthcare Foundation, Alliance Healthcare Foundation, the California Accountable Community Health Initiative, our IPP dollars, we've had ACEs Aware dollars. So we have benefited from so many supports that the state and partners have been giving us to make this happen. With that, today we have grown. We're at 6 community-based organizations providing today services to over 200 ECM clients and 100 housing clients. That's a workforce of 40 between the actual direct service, the supervisors, the managers involved. We also have 9 CBOs participating in CHW services contracts with 15 CHWs, 8 of whom are integrated into Children's Primary Care Medical Group. So we've done a co-located integrated model for a medically integrated CHW. The other thing we've done that I'm really proud of is we've worked with over 10 additional partners to really work on community referrals. So this was the other hypothesis. ECM, Medi-Cal members can't wait to be in ECM and have a lead care manager. All we have to do is call them once and they'll just sign right up. No. So we, and they pick up right away. So we have funded 10 community partners to do community outreach to really get the word out that this is happening and that you have access to these new benefits. And in last year, we accepted 300 community referrals and we managed them. They didn't all come to our network partner contracts. We spread them to whoever they belong to. We just were a centralizing place to manage community referrals. This is growing, and this year I think we're going to do over 900 of these. This is not a funded service, except that I applied for it under PATH. So I'm not losing money on it, but I'm just saying this is another role a hub can play. So I'm really here to say, I hope everybody in this room really takes a strong look at the hub model. We are happy from San Diego to expand and have conversations across the state. All of this starts with good conversations, trust, and good relationships. And to that end, Kamara is here with me, and I'll let Ignatius introduce her.
Great, thank you, Kitty. So I think you're getting the sense that this panel is really going to highlight the nitty-gritty details of how all these great concepts that are coming from the state that we're very grateful for actually play out at the community level, and both the challenges but also some of the successes. So I'm really glad to introduce our next panelist, Kamar Al-Wali, who is a domestic violence advocate, case manager, and community health worker. She works for a community-based organization called License to Freedom, which started out as a domestic violence multi-service organization, particularly for immigrants and refugees facing those kinds of issues, and obviously taking a trauma-informed approach to everything that they do. So Kumar, tell us a little bit about your role and how you see yourself as a community health worker now in this ecosystem where there's CalAIM and there's payment and there's contracts with health plans.
Thank you for the introduction, Ignatius. Good afternoon, everybody. My name is Kumar, and I'm the case manager, community health worker, and a domestic violence advocate working at License to Freedom. And we're also part of what Kitty was describing, the medically integrated programs. And a little background about my organization, License to Freedom. It started out many years ago as a one-person operation where our director, Dilkhaz Ahmed, was helping out women who were facing hardships in life due to being in a domestic violence relationship, and they didn't know how to escape it or didn't know how to get out. And her vision was that if she was going to help them with one thing, is that she is going to help them get their license to start driving and hopefully build from there to start looking for jobs and start looking for another place to go and hopefully enable them and empower them to get out of these relationships that were abusive and harmful to them. And that's how it started. She would go from door to door to our immigrants and refugees, the Arabic-speaking Middle Eastern women who did not know who to go to or talk with, and she would help them take them to the DMV, drive them, and apply for a license and get them the classes and the lessons needed to pass. And from there, our organization grew into with funding, grew into other services and help that she can offer, and she started hiring people. And today we focus mainly on legal advocacy and trying to do domestic violence prevention through restraining orders and legal work, but we also provide a ton of other services such as language, ESL classes, and we were able to open up another clinic that is only focused on mental health. And this has been revolutionary in our community here in San Diego because mental health is not a big topic or talked about enough in our community, and it's kind of taboo. And for us to be able to provide those services and mental health services in languages, either we have Farsi or Arabic speaking therapists or translators at all time, where those services were able to be provided in the client's languages, and that helped us promote them and get those clients the help they needed. Today, working as a case manager, we are community focused, and we do try to address the health-related social needs and tackle the unique experiences and barriers of our clients that get them from seeking the help they need and the medical care that they want. For example, a lot of these multifaceted challenges that they face are social needs that they have that are not being met due to language barriers and them not being able to go to somebody that can explain it to them or somebody that they can trust. And so this program has been very helpful because getting peers and leaders that are from within their own community, that they can talk to them in their own language and speak with them the same terms and words that they understand, has been very helpful and positive in to gain into their trust. And we're still like working on trust today, but it has been very improving to us to be able to have somebody from within the community that is able to provide these services. I take on many roles as a case manager and a community health worker based on what my clients need. So sometimes I'll act as an interpreter or translator for documents. Other times, whatever the issue is, like for example, transportation or if they have questions or concerns about their upcoming doctor appointments or something that they're not understanding, then we're trying to connect them with people that work within that organization that speaks their language, and we try to advocate for them when they receive these services so they feel more comfortable amplifying their voices and using it to get the help that they need. And we focus on the refugees and the immigrants, especially the women, because they have been underserved. And so for addressing these challenges, the goal is to empower those clients so they can get these services and do these things on their own. That's the goal and the hope. But today we're still working on that. Thank you.
Great. So finally, coming back to Los Angeles, Richard Ayub is the Chief Executive Officer of Project Angel Food, which started out providing food services during the HIV and AIDS epidemic here in Los Angeles. And Project Angel Food has now grown to provide all kinds of food services for folks with chronic diseases, and now medically tailored meals to really address not only food insecurity, but nutrition insecurity. So Richard.
Yes, good afternoon, everyone. Great to see you. Today, I'm going to talk about a presidential candidate, medically tailored meals, and Prince Harry. So let's start with the presidential candidate. Project Angel Food was created in 1989 by Marianne Williamson, who dropped out of the race and then got back in. She unsuspended her campaign just a week ago, I believe. So she is a spiritual leader, best-selling author, and she was really concerned about people dying of AIDS. And she was concerned they were dying of loneliness and also of malnutrition. So she found a church here in Los Angeles, just up the street at the corner of Fountain and Fairfax. And she got people to cook meals there and then got other people to deliver the meals. Some of the people who cooked meals are people like Bette Midler, and I think even Elizabeth Taylor did at one point. And, Cher came and offered to clean people's houses. This is Hollywood, folks. This is what happens. And so this is the beginning of Project Angel Food, and it was comfort food. Then when people started living with HIV, not dying of AIDS, we realized that if you give someone a healthy meal, it brings down their viral load and they get better. And we realized food is indeed medicine. Then when HIV became more manageable, we said this is too great of a gift to keep isolated to this population. So today we serve people with heart disease, lung disease, diabetes, kidney failure, all forms of cancer, and HIV/AIDS. All of the meals are grounded in research. They're all medically tailored. So for instance, if someone has diabetes, they need to bring down their A1C levels. We have a diet for that. If someone has kidney disease, they can't have too much potassium, phosphorus, and sodium. Now, I know potassium and sodium. Phosphorus, even to this day, I have no clue what it is. But luckily, our registered dietitians and our chefs know, and they come together and they make the appropriate meals. So in 2019, Project Angel Food was cooking, preparing, and delivering 650,000 meals a year. The pandemic happened. And you know what? It was build it and they will come. People kept coming to us asking for more help. And we grew by 46% in 1 year with no notice whatsoever. So we went from 650,000 meals a year to 1 million. Today, we're at 1.5 million meals a year. Thank you. Thank you very much. It's incredible. And so we have been involved in making sure that medically tailored meals are covered benefit. We want it to be a covered benefit of Medicaid, which is Medi-Cal in California, and Medicare. And we have been working on pilots. We and sister agencies have done research studies showing that these meals bring down healthcare costs, these meals keep people out of the hospital, and these meals improve people's health conditions and their quality of life. So we became a part of CalAIM in 2020, and we became one of the 14 new benefits. And medically tailored meals is a term that was invented by Project Angel Food and 12 other organizations. The definition of it, the intervention, everything was invented by us. And now, and I'm going to tell you exclusively, we are now going through accreditation standards, and we will now have a guideline to get accredited to be a medically tailored meal provider. That's going to be a big change for the entire business. And you'll see on the slide that we really believe in all forms of health equity. 77% of our clients are people of color. 97% are living at or below the poverty level. 62% are over the age of 60. And many say we're their only food source. So we're an intervention against homelessness. We're one of those safety net organizations that keep people in their homes and stop the flow of homelessness. So we talked about the presidential candidate, medically tailored meals.
Harry.
Now Prince Harry. So in Easter 2020, I think it was Good Thursday, the Thursday before Easter, I got a call from this PR firm called Sunshine Sachs. And they said, we have a very high profile couple that just moved from London that wants to volunteer on Sunday. Do you have an opportunity for them? I said, yes, we do. They said, what is it? I said, they can cook in the kitchen or they can deliver meals. They said, well, tell us more about delivering the meals. I told them about delivering the meals. Little did I know they were considering Meals on Wheels or us. And so Friday at 6 p.m., when everyone's gone, they called me up and said, yeah, they're coming. I'm like, okay, great. Let me figure out a route. Luckily, I was kind of anticipating they might do it. So we figured it out. And they said, we can reveal to you that they are now the Duke and Duchess of Sussex. I said, oh, wow. And so I said, can we take pictures? Blah, blah, blah. All the protocol things. No, we cannot take pictures, which was really disappointing. And then, what should I call them? And they said, ask them. I said, okay. So they came on Easter Sunday. I greeted them. And it was first Megan. I said hello to her. She said, please meet my husband, Harry. I said, hi. And they're wearing N95 masks because this was the height of the epidemic. I gave them a tour of our kitchen on Vine Street. And there was a moment when we were back in the kitchen where we have dry storage. And we have a chef whose name is Angel. And they had told me beforehand, as I asked them, how do you want to be addressed? I said, Duke. They interrupted me. They didn't even let me say Duke and Duchess. They said Harry and Meghan. I said, okay. So we go back. This Chef Angel comes, and I said, Chef Angel, please meet Harry and Meghan. She's looking down, and then she looks up. And she screams, she starts crying uncontrollably. And Megan says, oh my God, I would hug you if I could, but because of COVID, she couldn't. And then Harry asks, is your name really Angel? And she said, yes, my name is Angel. And this was the most beautiful part. They went on deliveries to our clients, and they wanted to do the deliveries alone. And I said, I'm sorry, I have to go on at least one. It's our protocol. It wasn't our protocol until that moment. I'm like, I am not going to miss going on deliveries with Prince Harry. So we went to Burbank, and we delivered to this client by the name of Frank. Frank has cancer, and Harry put the meal right at the doorstep, stepped back 6 feet, and started talking to Frank. And the entire trip, I was looking for moments of Princess Diana in him. And he asked, he said, how are you feeling? That was the first question. Frank said, I'm okay. I had treatment yesterday. And then I said, how's the food? He said, it's delicious. And Harry said, delicious? Like he's thinking medically tailored meals. Are they delicious? And Frank says, yeah, they're delicious. And I'm kind of noticing that he has no clue Harry and Meghan are there. I go, Frank, please meet our newest volunteers, Harry and Meghan. Nothing. He's like, Project Angel Food is so great. I love it. He's just really oblivious. And then this was the moment when I felt Princess Diana was in Harry. He said, do your neighbors check in on you? It's a question I have never asked any of our clients. And Frank said no. And Harry said, we all need to watch over each other. And that is what we all here, all of us are doing. We're watching over the people that the neighbors don't watch all over. So thank you all very much for being here. It's my pleasure to be part.
Thank you, Richard, for sharing truly a Los Angeles Hollywood story that we can all repeat. So I'm going to save a little bit of time for folks to ask questions, but I want to come back at least one cycle with the panelists and go back to Kumar. I think we're hearing a lot, including in this last story, how the members of the community that need these kinds of services the most need a much more whole person integrated approach to healthcare and social services, often don't trust the systems that are set up to supposedly deliver those services to them. So Kumar, I'm going to come back to you and say, clearly by the story of the founding of License to Freedom, you've established that trust with the community. So what lessons can you share that others might try to apply for whatever their communities are to overcome that lack of trust with the community providers that are supposed to be serving them?
I would say the most important thing when working with a specific population is that when a client comes in, that they see somebody who looks like them. They speak to somebody who can understand them in their native language without a third person or translation over the phone. Somebody who can relate to them and they can relate to. That would be the most important step into building trust. And a lot of the programs and the initiatives that have gained trust within our community that I noticed are the ones that are peer-led and the ones that are community centers and centers that are already established within our community that people have already built that relationship with, and we can use those as platforms to share those health-related information.
Great. And then Kitty, you also mentioned sort of convening health plans and community-based providers and literally feeling like they're speaking different languages and don't understand each other. So can you share any breakthroughs or any insights of, you obviously ended up in some ways being that interpreter of trying to like say, no, this is what the health plan is trying to communicate, and similarly, this is where the community-based organizations are coming from. So any insights that you want to share of how you build that kind of communication and relationship?
I think that, I think the folks sitting at our Accountable Community for Health table recognize that for a long time, we were talking about Medi-Cal members and we were talking about the CBO clients. And then a light bulb went off that this is the same person and that these are Medi-Cal members who the community-based organization is serving day in and day out as a trusted resource in the community. And when that was sort of understood at a very deep level, that it's really the same population. Somebody isn't just a siloed Medi-Cal member or a siloed client of this CBO. They're experiencing, obviously, themselves as a person of a community, and that allowed us to have those breakthrough conversations where this was prior to CalAIM to be able to say, Medi-Cal MCOs can't do this anymore without CBOs as your integral business partners, because your members are already using these services and would benefit from a more systematic approach to making sure that they have access. And this sort of corresponded to an increasing conversation around the social drivers of health and health plans feeling a responsibility for the first time ever maybe to really look into and understand and address their members' social drivers of health. This was then Health Homes Pilot gave us an opportunity to say, we can really do something around this. There's actually dollars here and we can make these relationships happen, which I felt really important because there was a concern that Medi-Cal health plans would try to solve this problem themselves by hiring their own CHWs, for example, or their own community-facing workforce. And we have seen some of that. But to be able to say, we've been sitting at this ACH table and having conversations. This is the moment where we can make this all come together and have dollars and contracts and data now flowing in a way that works for both sets of partners. And I think that helped, that understanding that we aren't siloed, this is whole person care.
Great. And so let me come to you, Tony. I think it's, for me, really important that it's the Fresno Community Health Improvement Partnership. It's not the Fresno Community Health Improvement Project or program. It's really about the relationship. And what's remarkable about what you've been able to achieve in Fresno is how multi-sectoral it is. You've talked about it's not just the health plans and the county health department and the community-based organizations, but it's also the schools. It's also law enforcement. It's so many other kinds of sectors that really need that whole community approach to tackling some of these health disparities and health inequity. So talk a little bit about how that partnership holds together, even if not everybody's involved in everything.
Thank you. And I want to start by just thanking you for having me go first and not after Richard.
Yeah.
So thank you for that. I think, it's the work that we do at FCHIP is embedded in our mission. Our mission is to help improve the health of our community by working together with a shared purpose and commitment. Shared purpose and commitment, right? So when we come to the table, FCHIP is recognized as the local convener with stakeholders, as well as health plans and other CBO partners. So when we come to the table, we start with what is our shared purpose? What is our shared commitment? And then we identify the gaps. We identify the opportunities that we can work together on. And we prioritize. We can't boil the ocean, but we can certainly tackle a few common items that we find of interest, and of course that are win-win situations for the partners as well as FCHIP. So that's our approach.
Great. And so finally, Richard, coming back to you, Los Angeles County is so big in California, but also if we compared it to the size in terms of population, at least, of other states even. So how are you able to sort of hold all the relationships with the various plans and systems here to really make the case that medically tailored needs are in the interest of their health plan members?
It's actually a challenge, but in LA Care is the top provider of Medi-Cal. I think 2.6 million lives they cover, which is huge. And they subcontract to Anthem and Blue Shield Promise. So when they do something, the others really follow. LA Care got invested in medically tailored meals very early on. And I don't think it's just because the CEO is on our board, but I think it does help. He said that of all 14 new benefits with Medi-Cal, he believes medically tailored meals are the one that have the biggest ROI or the most measurable ROI. And I think other health plans see that too. And something that's been a challenge is we started in 2022 with CalAIM, but we negotiated contracts a year or earlier. By the time the contracts were in force, there was 9% inflation, and the meals were not paid the correct price. To their credit, we went back to 2 health plans. They renegotiated, and they increased the prices.
Great.
That was a real partnership when they recognize they do that.
Great. So I want members of the audience to come to the mic and ask any questions that you have of our panelists.
Thank you so much for those presentations. My name is Reggie Tucker-Seeley. My question is about how do we link these programs to health equity explicitly? Because I think sometimes we forget that health equity is a process and an outcome, and that we often just focus on what is this outcome. And so can you talk a little bit about sort of how your specific efforts are linked in the community explicitly to either health equity or health disparities reduction?
So I would say Kitty or Tony, do you want to start?
Sure. So we do a lot in so many different ways where we explicitly link the work of both our accountable community for health and neighborhood networks to building equity. So one of the things we believe strongly is that by engaging smaller CBOs in CalAIM in a way that makes it very accessible for them and very accessible for this workforce to have thriving positions and jobs, that is creating a health equity. So that is a part of our solution that we are actively working on every single day, is to make this opportunity available, but beyond available, to really raise up the voice of community-based organizations as a new important group that is a part of the Medi-Cal network. And so it comes back to power and influence and dollars, and by creating a network where CBOs can actively have a voice in the way that they participate in the Medi-Cal program, they can have access to the same contracts that other Medi-Cal providers that are healthcare organizations would have, and they can build their voice and their power over time, because we understand that healthcare operates and power is accumulated by networks of member lives. So there is a reality check of what creates power and influence in the healthcare system as it exists today. And so to build a CBO network is to give power and voice to a new class of Medi-Cal providers that, up until now, have not seen themselves as Medi-Cal providers. And this is a part of the journey that we go on with our network partners. And Kumar can tell you a little bit about the kinds of meetings we have, the kinds of conversations we're having, where it's a vulnerable space, it's an open space, it's a trusted space. So the CBOs, I came from the FQHCs, where it took a few decades to get folks to go into IPA networks. We've passed all that. We're already building trust. We're already sharing information. We had a recent conversation where one of our new CHW services partners said to the group in these monthly meetings we have to other employers, I can't get my HR department to classify this new CHW job at the equitable pay rate I want to start at because it does not require a college degree. And for internal equity purposes at my organization, which is a large organization, actually with sites all over the state, that HR department looks at internal equity to set the starting wage, but that's not an equitable wage for CHWs. So they were able to take data from all of the other partners sitting at this table, go back to their HR department and say, CHW starting rates, even though it only requires a high school diploma, and not even actually, should start at this rate to keep it equitable with what's going on in San Diego and to be aligned with living wages, and that worked. And that's a really real life example of the kind of transparency and trust and partnership that we're coming out of the gate with as a Medi-Cal provider group.
Great. Tony?
What a great question. What a great question. I will take a stab at it by giving you two different angles, or try to give you two different answers. The first answer at the resident or community level, how FCHIP and Fresno Hope are building equity there. The support that the CHWs are providing residents, right? And an example is a student at Part Year Unified who was involved in gangs and was this close to getting expelled. Their whole future was going to be derailed at that point. The CHW became aware that this was happening, and we engaged the stakeholders at the school site and asked them if they had received trauma-informed training. The answer was not, this unfortunately. So when we stepped in and asked the principal to give some time for the student, and so that their staff would be able to receive some training about being trauma-informed, they realized that there's a lot of layers to peel back from somebody involved in some of these behaviors, right? And so to make a long story short, it was a successful intervention, educating and training the staff, and now being able to stop the student from receiving those negative repercussions of their behavior, right? Based on the fact that that student had suffered a severe amount of trauma and was acting out based on their trauma, right? So I think as we think about inequities, we also have to think about our stakeholder community and what inequities exist there, from just an example, from being trauma-informed, right? Thank you.
So we're at time, but I at least want you to be able to ask your questions so that we get them.
Okay. I'm Karima. I'm a physical therapist. My first life was actually a high school teacher. So I'm kind of coming at all of this from a very different perspective than most, I think, here. And having Tony with FCHIP and stuff makes a huge difference. But one of the things that I find really frustrating as an ex-high school teacher is, and then having to educate my patients on a daily basis, is the fact of how uneducated most patients are in relation to healthcare in general. Nobody gets the chance to actually get educated. And when we talk about trust within a community, when we talk about trust with any healthcare provider and their patient, I find that this is hugely lacking. And I find that education, starting at an early place, is something that I'm wondering if organizations are looking at from a community base. Like, can we come up with programs that are preventative, that are hitting families, teenagers and high school, and their parents and stuff, and getting into, this is what you need to know so that when you go through your healthcare continuum, this is what to expect. Don't get frustrated when you have this happen. Nobody has the chance to do that. And I find that that's one of the things that I'm wondering if that's something that we can look at from a preventative point of view, and hitting up all of these community-based things, if there's a way to do that, because I think that's one of the big missing factors. And that's just, if there's a way to do that, I think that would be huge across spectrums for everybody.
So let's leave that, rather than asking the panel to respond, since we're at time, let's leave that as a challenge for all of us to think about taking away, no matter what role you have, how do you actually engage members of the community, your patients, your members, your clients, in educating them about these very, very complex systems as we're trying to negotiate and figure out how they work better together. How do we empower our patients, our members, our clients, our community members to navigate those systems for themselves in a more successful way. So join me in thanking this terrific panel, and we're at a break.